IV antibiotics. Empirical IV antibiotics are necessary in these cases. Another person had hinted about the case that had presented, was asking about the rationale of antibiotics in that case. Truly, antibiotics are not routine in management of diarrhea. However, commonly we know that because of diarrhea, basically it's a gastroenteritis. Knowing whether it's viral or bacterial or other insults causing it is very important to notice. Now, in this very case, you saw in the presentation that the stool analysis showed that there was no blood, and usually antibiotics are given out in patients who have this dysentery, cholera. However, this very case, the stool analysis showed pus cells, which were nine pus cells, and the normal amount of pus cells in stool is about 0 to 4. So this was still pointing to probably a bacterial form of gastroenteritis. And the fact that usually these patients with the viral gastroenteritis respond to within about 3 days without any antibiotics, and this is a child who had been diarrheating over 5 days, spiking fevers, and then still with the CBC, not very good. The best thing would be doing a stool culture, but of course difficult in our setting, a stool culture and also blood culture. But then the CBC was more of neutrophilic dominant monocytic and not lymphocytic. So still having a very sick patient in shock and showing the markers of pus cells, about 9 in stool, we felt the best thing would still to cover the patient on antibiotics, and the choice was to avoid gentamicin, of course, in this case, since the patient is in shock and is at risk of developing acute kidney injury. I think that's what I wanted to throw up as we wait for the team to come in. I hope the team is back there.
Yeah, and I think it was so important. I think it was so important addressing that question, and I think 2 or 3 other people had one question. So it figures, yes, I saw 2 ends, but I think the paper is back. Maybe they could talk, and then we can wind up with the 2 hands that I saw. Yeah.
Okay. Great. Are you able to hear me now?
Yeah, we can.
Yes. Great. So we are at the point of actually finishing this session, and we got a lot of interruption. But thank you, Dr. Jimbo. You stood up, and then Dr. Levala, you covered us up when we are off in the room here. But great. We are actually in the summary point.
Yes.
And I'm glad the questions have been coming up. Unfortunately, all the questions that were on my gadget, I couldn't see them. But if anybody has a question, please raise up your hand. In the next 5 minutes, we could be able to answer questions. Then we close the next 10 minutes. Yeah, Dr. Kalat is going to do the summary.
Yeah, so as the questions are coming through, in summary, we talked about the causes of shock. I'd like to quickly run through them just as a reminder, just to give you, as a clinician, an overview of the things that you have to do in the different forms of shock. So if it's to do with cardiac output, you have to manage either hypovolemic shock. So if it's hypovolemic, replace what has been lost. You're going to replace the fluid, you're going to replace blood, the different forms. Special considerations are for managing patients with burns, managing patients with malnutrition, as well as managing patients with severe anemia. So be cautious about that. For cardiogenic shock, manage what's causing the heart to fail. If it is heart failure, you go into the heart failure regimen. After resuscitating, you have to manage the cause of heart failure. If it is a myocardial infarction, manage the myocardial infarction depending on what it is. If it is valvular disease, you start on the bundles that are used to manage valvular disease. Okay. If it's obstructive and there's a pulmonary embolus, you have to now go down the route of managing a pulmonary embolus. Okay, there are protocols that we use to manage these things. If it's a tension pneumothorax, the chest tube has been inserted, we now go down the route of managing post-chest tube insertion, okay, and all the care that goes into that. If it's a tamponade, the cardiac people will take over and manage it accordingly. If on the other side is to do with systemic venous resistant, we manage anaphylaxis accordingly. So those ones need to be closely watched and monitored for escalation of the worsening of the anaphylactic condition. Okay, so epinephrine, steroids come in, as well as airway protection interventions. Okay. If the cause was sepsis, we talk about the sepsis bundle. Okay, sepsis bundle comes in, antibiotics, fluid, pressors, and the rest as they come along. Mm-hmm. And finally, if it is neurogenic, at that point you have to interface quickly with orthopedic surgeons to see how to safely, again, either stop the injury to the spine or protect it and then hand over to those that take over. So in summary, those are some of the key things. And of course, if it's hemorrhagic, the management of the trauma continues as we've seen in other traumatic injuries. So in actually, I hope that has been able to bring it together.
Great. In other words, SOC is complex. Patients with SOC are always available within our clinical setting. And remember that every type of SOC has different protocols to manage them. The most important thing is to do your primary survey in the first 5 minutes and be able to identify these problems clinically. And remember, Dr. Karan said, start with airway, proceed with the breathing, up to the time when you have reached E, meaning that you address every component of the problem that you find before you go to the next stage of assessment. Dr. Kalanzi, thank you so much. I would like to come back to the participants. And the participants, I would like you to ask your questions. And I want you to direct your question to individuals whom you want that question to be answered. And I want you to keep your questions short and brief because we have very few minutes. And once the question session is going to be done, we'll come back with the polls and then you will answer the questions on the polls. I would like to take Walter. Walter, I saw your hand was up. I want you to ask your question.
I'm Dr. Walter. I'm not actually asking a question, just a small contribution.
Excellent. Go ahead.
I hope you can hear me.
Yes, clearly we can hear you. Go ahead.
Yeah, about the question you're asking about, yes, about malnutrition in children. Basically, just thank you, Dr. Level, about the clarification. The person asked about Resomal and the IV fluids. We need to differentiate the two things. There's what we call dehydration in malnutrition and then shock malnutrition. Those two are different. And then most times for patients who are the pediatric, the problem that prompts the mother to come to hospital is not necessarily like the child is malnourished, but there's an infection that is ongoing. And most times the shock they're having is a septic kind of shock. That's what you should also know that can help somehow to direct your management. And then the other thing, our anemia for transfusion for the malnourished children, please, it's not the usual normal HB of less than 6, but less than 4. These children that are malnourished are very, very sensitive to fluid overload. Given generally the general population of the pediatrics is very sensitive, but these become more sensitive. We've lost a few children because of excessive fluids. And then while you manage shock, remember, please, you're not alone. It's a teamwork. If you need to consult, please go ahead and consult. That's my contribution. Thank you.
Excellent, Dr. Walter, for that contribution. I really appreciate. You can see the benefit of having a specialist who's answering very specific questions in reference to that. That means it is very important for us to consult. We are not everything. We have other people who have very special knowledge in those areas. So consider consulting them. And let's go to the second person whose hands up, Ezekiel Dapa. I would like to take your question. And as I said earlier, be specific and keep your question brief.
Okay, thank you very much. My question will go directly to that doctor from Tanzania. And it's about the ABG findings she earlier talked about concerning when the ABG shows acidosis or alkalosis or there's lactate, then there is a problem. So I want to know the management, if it is like acidosis or maybe the lactate is, at what level of the lactate that needs some management, and what are the management? Thank you.
Okay, thank you so much, Dr. Ezekiel. Dr. Jimbo, this question is for you. How do you manage a person who is acidotic, and again, at what level of lactate can you be concerned?
So management of acidosis is very technical. One, normally we manage acidosis with medication only when the pH is less than 7. So acidosis is any pH that is less than 7.35. But usually less than 7.35, it just tells us where we are going and we need to do anything for it to not go less than 7. But once the pH is less than 7, then we do give sodium bicarbonate according to weight. Okay. Right? So this is
yes.
1.
Okay.
2, so anything less than 7.3 is telling us this patient is acidosis. So whatever is causing the acidosis, we manage that. So if it's dehydration, if it's shock, or if something, manage that. But once it's less than 7, you don't know the cause. Whatever the cause is, you have to give sodium bicarb. 1. Question number 2 of lactate. A lactate of 2 is a cutoff point. Any lactate above 2 is telling you this patient is in shock. So if you're managing your patient and this patient is having a lactate of above 2, literally it tells you that this patient is in shock. So when a lactate is 7, it's 8, it's 9, it's good. When you're managing your shock and say, we have talked about reassessment after half an hour or reassessment after an hour, you measure your lactate again, and your lactate has moved from 6 to 4, it tells you that this patient's shock is improving, versus a patient's lactate was 6 and now it's 12. It tells you you're not doing much to manage your shock. So I think those are the count of 2 is a lucky number. Anything above 2, it's shock. But another thing, use it to know whether you're managing shock the appropriate way and whether your shock is improving.
Okay. Yeah. So in other words, lactate is a biomarker, which is a very good indicator where if it is more than 2, things are getting worse. If it is below 2, you are doing a good job. That's what I hear Dr. Jimbo is saying. Dr. Kalanzi?
Yeah, and some of the other physical findings that can show you progress or the response to therapy include level of consciousness, blood pressure, pulse rate. They're not necessarily very, very conclusive, but they're some of the clinical findings as well as urine output. So if you look at some of those parameters, temperature, body temperature going up, if you see them changing in the right trend, as well as the lactate, if you have it, are markers of good progress post-research.
Okay, excellent. Members, a post-test is running on, and I'm only going to take 2 last questions. And while the post-test is running on, I would like to pick 2 questions only. And one of the questions I'm picking is from Catherine, and that will be the last. Second last.
Thank you very much. The question is directed to Dr. Kalanzi. I wanted to ask, it has already been asked in the group, and I wanted to just re-echo the question for clarity. When you are giving your boluses, say your 30 mils per kg in 30 minutes for the children and your 2 liters for the adults, how many boluses can you give before you decide to take more drastic measures or to give the epinephrine, or how many boluses can you give before you change your plan of management for the patient in shock?
Yeah, thanks, Luis. That's a nice question. And I wish I could give you a magic number, 1 or 2 or 3, but unfortunately, there are multiple factors to consider. 1 is the underlying cause, and then 2 is the efficacy of your ability to check response. Okay, so if the issue was hemorrhagic shock, and your ultimate solution to the shock is blood. So for hemorrhagic shock, we don't have a lot of leeway to give multiple boluses of fluid. So for that one, we don't go way past about a liter. Okay, after getting past 1 liter of bolus fluid, we want to now consider moving on to either pressure or blood itself. In other situations such as severe dehydration, you have much more leeway, because with severe dehydration, vascular volume is down completely. So for that one, you can give a lot more, because they're not anemic. Their issue is that they just have a very small plasma volume. So depending on the cause, you have to look at the 2 things. If they are neurogenic and after the first bolus of 1 liter, there's no response, immediately that patient needs vasopressin, because the issue is not really with the volume, it's with the vascular integrity. If it was hemorrhage, they need blood. They don't need more fluid, they just need blood. So it depends really on the underlying cause. And so I'd rather we look at a case, and depending on what's reversible about that case is when you decide when the bolus is not responsive or not.
Thank you, Dr. Kalanzi. Pius, you are the last person to ask a question. And once Pius has asked the question, I'm going to go through the panelists to give their last remarks. Pius?
Thank you very much for the opportunity. The presentation has been good, much as we had those breaks and because of internet. So my question is, what is the role of the anesthetist in the management of shock, particularly does it require sedation at one point in case we need to manage shock?
So I'll answer maybe with Gimbo. Again, it depends on the underlying cause of shock. There are certain forms of shock that require both circulatory, airway, and ventilatory support. So in the event that the patient needs that, common examples are severe burns, severe airway burns, but as well as patients that come in with severe anaphylaxis. They ultimately will need airway protection and vasorespiratory support, as well as those that have severe trauma who have to be sedated to manage them. Yeah. So for those patients where you anticipate that their care is going to need advanced management, especially of the airway and vascular respiratory system, the anesthetist has to be called in. On the other side, if you have a patient who is severely dehydrated but fully conscious, there's no need to require advanced respiratory care. So those ones don't need. But if you anticipate that this patient's progress of their pathology is going to need further critical care, then you have to bring in. And the big ones are severe burns, severe anaphylaxis, myocardial infarction, tamponade, as well as things like sepsis. Sepsis nowadays as well, some patients end up in ICU because of their severity. So your clinical judgment, and Gimbo likes to say, has said this word a lot, what is it called? Gimbo, what's the word you just said? Gestalt. Gestalt, yeah, that word, gestalt. You can tell this one is not going to, when I leave the ships, they'll need care. Then you, So Gimbo, take it over with your big one.
Jimbo, take over from there. And I would like Jimbo also, after that, you summarize, give your final remarks, then we'll come back to the rest of the panelists.
No, I don't have a lot to add with what Dr. Kalanzi said. He literally summarized what is there. Everybody has a role. If you're an anesthesiologist and you live in a place where not everybody has an emergency expert as good as Kalanzi to do an airway situation. So if you're an anesthesiologist, you learn this. Like, so when you know, like, there could be patients who are presenting in shock, who might need, their heart is going to fail. For us here in Tanzania, the heart failure is called Jakaya Kikwete Cardiac Institute. So it will take time until they reach Jakaya Kikwete Cardiac Institute. So what happens in anesthesiologists in the rural areas, they help with intubations so that they can buy time for this person to come to Jakaya Kikwete Cardiac Institute and solve the heart problem that is causing the heart to fail. So there are a lot of those things that, and I would like to also echo what the other person said. I think a pediatric person talked, it's teamwork. So not only the casualty people will handle. If you're the anesthesiologist who can know the right amount of sedation or the right amount of paralysis to give to this person so that they can intubate or get that advanced airway, et cetera, then you should take in and be part of the team. So everybody has a role. So whatever Joseph said plus teamwork, that's what it takes. And in terms of summary, what I said, I'm lucky to be one of the Tanzanian who visits places that are all not national hospital. And what I tell them is, like, whether you're a nurse or you're a doctor, whatever you learned in school, try and bring it back, because at the end of the day, science is science. Like, you can't beat around the bush around science. If that person is in shock and you're told we'll need a 30 mils per kg bolus of fluid, they will need that. You're told that this bolus, if every other thing is constant, they don't have a problem, they'll need this bolus given to them in 30 minutes. That's the science. But once you start giving them a small line of yellow and you're trying to give fluid which this person should get in 30 minutes, in 2 hours, you're going up beyond science. You're not saving the life of that patient. So let's still remember our science. Let's go through our protocol. Shock can be managed by any level. It doesn't take you to be in a national hospital, in a private hospital. basic shock, which interventions can be done at any level of hospitals. Big things, buy time for the person so that they can reach in a place where they can get the big things. ABG, lactates, as Joseph said, those are all luxuries, but you can still pick your other signs of ICPs. You can still pick your other signs of this person is in shock, right? So I think that's my take home. Like at any level, you're still a clinician, you're still a nurse, just remember your knowledge and using it to save life.
Thank you, Dr. Jimbo. It was very, we are very happy to have you as a team on this panel. Let me come to Dr. Livala. Livala, doctor, can you give your last summary of this conclusion? You presented a very interesting case. Give us your last remarks as we close.
Thank you very much, Mr. Cliff and the team. I think a lot has been discussed. The take-home message from my side is that we need to follow the protocols. Things are well elaborate. We need to follow the protocols. We have seen how we need to assess the patient in the order of following the primary survey, the secondary survey, and taking the ample history, and then the teamwork. I think with following that, we shall really be able to manage patients of shock rightfully. And the other important thing is really monitoring that we have been emphasizing. Monitoring vitals, looking at the case and how sick the patient is. Sometimes you need to monitor vitals of about 15 minutes. Other patients, you need to go even up to 30 minutes. So monitoring vitals, and the vitals have actually been really recorded. Looking at all the vitals, continuous monitoring, and then still documentation of whatever we are doing. One other thing that I've noticed in our setting is the challenge of documentation. In the cases where we see patients, many health workers, you find the patient has seen a health worker has seen a very sick patient and has not documented whatever they have done at what time. So in one other thing that we need to record also that we had left out is really documentation, and then the balance sheet. The fluid balance sheet has to be followed, and then looking out for the output still, and then balancing. And then the other thing that we need to do the frequent chest examinations to look out for fluid overload signs, like the basal crackles that would really set in. Otherwise, that's it for now. I look forward to the next case presentations that we shall have. And thank you, back to you, Mr. Cliff. Thank you very much.
Okay, great, Dr. Livala. Let me come to Lucy. Lucy, your final remark to the nurses.
Okay, thank you very much, Mr. Cliff. My final remark is that, what I've learned from this session, take home, is shock is not managed by doctors alone. Nurses are supposed to be involved, and we can actively participate. Since we are the ones who are most times in touch or next to the patients, we early recognize and please let's have early intervention, call help when necessary, or if we can start what is necessary, we should be able to start. Then, as has been emphasized, most of the things we do, doctors will come intervene, but the largest part of it is left for us, and that we should take it up upon us about documentation. We most times do what we have done and what we've been told to do or prescribed, and we don't document, which leaves a gap, and this not documenting will life costing, because some other person can come in and load the patient or give more fluid since we didn't document what we had given. So let's take shock as an emergency, and we should always be in and take it as a serious thing. And as nurses, let's participate in all aspects in management of shock. Thank you.
Thank you very much, Lucy. And coming to finally, Dr. Joseph, what's your last word? You started with the vehicle. What are you going to end with?
So my car that was shaking.
Yes. Where is the car is now?
So when a car shakes, doesn't mean it doesn't have fuel. It could be many things. So when a patient is in shock, it doesn't mean you give them normal saline. So not every patient that is in shock needs normal saline. Take the time to find out what the cause is. The causes can be different. If you go offside, the patient will end up bad outcome. So take your time, as we're doing what we're doing systematically, but take your time to find out what the cause is. bring the science that we're talking about, but then look at the patients. Look at the patients. Look at the patient. They will tell you everything you need to know about what's going on. And usually the best stuff is when the patient starts to improve, everyone smiles and breathes, and we clap our hands, but it's because we take our time. And then finally, I say thank you, and it's nice to see Gimbo again. I last spoke to her a very long time ago, and it's nice to see that we're now having a connection with our colleagues in Tanzania. And hopefully the other session we'll have, you guys will host it and will tell us about the case from your end, and we'll give you some of the advanced things we do in Uganda. I'm sure things that you will never hear of, but made in Uganda. And you also share your experiences from Tanzania. Thanks, and I appreciate it. Asante sana.
Okay, great. We are going to come back to the summary. I will ask Dr. Thomas shortly to go through the summary. But for me, this has been quite exciting. We started with a car which was shaking, but now this car is driving because Dr. Jimbo has identified the solution. Dr. Kalanzi technically identified the solution, and then Lucy was monitoring it. And the analysis was done mainly by Dr. Levala. And I'm quite excited that the objective that we set today was to, to learn how we can approach a person with the volume, treat person with shock in terms of volume resuscitation. And this has been quite exciting. And I noticed that there were quite a number of up to almost reaching 300. That was quite exciting. And I want to thank all of you for remaining with us, despite the fact that there was a challenge with our network here. Dr. Jimbo took over, Livala took over when we were still locked down in our network. This has been a great teamwork, and the work has been achieved, and I'm quite excited. So I'm going to ask Dr. Thomas, what is the outcome of our pre-test and post-test?
Yeah, it has been interesting to run the pre and the post-test for this session, and participants have shown a significant shift in terms of the knowledge they've gained from the session. So thanks to the experts, test presenter, and everyone as a team, people who have been on the chat asking and answering questions. Most of the questions have been answered of the participants, and they've chosen the right answers. The only question we need to clarify on is question 3, which was asking about cardiogenic shock and how which ionotrope is suitable to support someone in cardiogenic shock, because we can see 68% of the participants chose epinephrine, and yet the correct answer was dobutamine. We need to just mention about that so that people go home knowing that that's the right drug to use. Perfect. Otherwise, I appreciate people for attending, and then also we shall have our next session in a week, not 2 weeks, because we are doing end of year marathon. So we are going to do in a week. I shall be happy to see you on Friday. Back to you, moderator, to comment on question 3.
Yes, question 3. You realize epinephrine if you give it, it will cause vasoconstriction mainly. And then, but dobutamine is the best alternative, because it is able to maintain consistency of the integrity of the vessels during shock, and that's the reason why it is quite important. And I'm aware that dobutamine is not a very common drug, and what this tells us is that if shock remains untreated for a long time, you are likely going to need more complicated drugs which may not be readily available. In summary, what I wanted us to focus on is that let's identify shock early, treat it early. And I would like you to go online and probably read more about dobutamine, because we are now time short, so that you can learn more why this was important. So we are going to go to our final session, and I would like all of you to put your videos on, and we take a picture so that we document this, that this has been achieved. And it's quite unfortunate that many of you have already left. Okay. The panelists, put your videos on. And everybody else, where we definitely recognize all of you, wherever you are. And I think we're going to take the shot about 7 times, because each screen brings about 40. And about 20, we'll take it several times. So, Secretariat, please go ahead with the pictures. And when you are done, let me know.
We are taking the shots. We are happy to see everyone. I can see a few people I know. I'm seeing Dr. Nagadia in
Yes.
I'm seeing our case presenter. We are so happy to have you. And then all other people, we are excited to have you. I can see a few of my classmates. Please, thank you for attending. I hope you gained a lot from the session.
It was educative.
Thank you too.
Bye.
Thank you.
Dr. Cliff.
Bye-bye. See you again after 1 week.
See you in a week.
Bye-bye. See you in a week.
Bye-bye.
Bye.
Thank you. Bye.
Bye-bye.
Thank you.